No problem. I'll do that.
Good morning, our teachers and colleagues. This morning, Dr. Tai will be taking practice question 4A. Okay, so Dr. Tai, you have the floor. You have 10 minutes, and then thereafter, we'll take comments and questions from the participants first, and then from our teachers. Okay, then go ahead.
All right, thank you, Chief. Good morning, our teachers, senior colleagues, I'll be taking practice question 4A. The question goes thus: 24-year-old male house officer in your hospital's emergency department with history of fever of 3 days duration with associated generalized weakness. He took some antibiotics with no relief of symptoms, so he decided to take anti-malaria medication. 2 days into using the artemether lumefantrine, he developed cough and took amoxicillin and clavulanic acid, still with no relief. 2 days later, he noticed headaches, sore throat, tingling sensation in his ears, and a rash, making him present for management. So looking at this question, is house officer having fever for 3 days, and he has treated common causes of fever, took anti-malaria, and is also taking antibiotics for the possible upper respiratory tract infection / lower respiratory tract infection with no improvement, and developed sore throat, tingling sensation, and a rash. So these are the questions I'll be attempting. One, mention 4 other questions you would like to ask him. What is the most likely diagnosis? List 4 differential diagnosis. What is the vector of the disease? What is the mode of transmission of the disease? How will I investigate the patient? Then how will I manage him? Then list 4 complications, and what are the prognostic indices? So for the other questions I would like to ask him, number 1 is, I'm going to ask him if he has had any recent contact with a probable or a confirmed case of Lassa fever within 21 days of the onset of the fever he's having. I also want to establish if he has traveled to any high-risk area of Lassa fever. Then I also want to know if he has had any contact with fluids, body fluids or tissues of the patient with a febrile illness or symptoms that is highly suggestive of Lassa fever leading to death. Then I also want to establish other symptoms and complications that might have set in by asking if he has any history of abnormal bleeding and every other, maybe point to AKI or a CNS complication. Right? So what's the most likely diagnosis? So my likely diagnosis would be a suspected case of Lassa fever. Then what are the other 4 differentials I want to consider? I want to consider a streptococcal pharyngitis. I also want to consider a meningococcal meningitis in it. I also want to consider leptospirosis. Then also consider other viral hemorrhagic fever patient. So what's the vector of the disease? The vector of the disease is a multi-mammal rat called the Mastitis latalensis. So what's the mode of transmission of this disease? So the mode of transmission of this disease is that the rodent contact could be a direct or indirect contact with the rodent urine, physics or inhalation of aerosolized rodent excretion or consumption of an infected rodent as food. Then if there's a person-to-person contact, whether the blood, urine, or any other bodily secretions of an infected individual. So how will I investigate this patient? The investigation of this patient will be divided into 2, the diagnostic investigations and the supportive investigations. So for the diagnostic investigations, I want to do a Lassa virus reverse transcriptase polymerase chain reaction. Then I also want to do an ELISA test for serology, which can either pick the Lassa antigen, the IgM, and the IgG. So the supportive investigations will further help to check for complications and also establish diagnosis and also to prognosticate. So they will include the full blood count and platelets. Full blood count can show the leukopenia with the lymphopenia, while platelets can be low. The liver function tests have been tested in the AST, which value greater than 1 international per liter is a prognostic factor. Then I also want to do your malaria parasite test. My private case of malaria just to hospital, which is something must do in the guideline. Then also to do urinalysis to check for proteinuria and hematuria. Then electrolyte urine creatinine is very important, like I said, complications like potential. Then others include the clot profile. Then others will be based on the complications that might have developed. So how will I manage him? So haven't established that is a probable or suspected case of the Lassa fever. So what I want to do as soon as possible is put him in holding area and institute the prevention measures. Then I will allow the relevant authorities and other disciplines that could help in the management of top of this infectious disease. So then after the laboratory investigation, both the diagnosis and support investigation are taken as earlier highlighted. They will transfer this patient to the suspect bay for to commence treatment because it's important to commence treatment for the sick because that the important prognosis is started as early as possible. So I'll start the patient on ribavirin, either using the RUA or the McCormick's regimen. So this is the RUA regimen that I've highlighted there. So I'll start the patient on IV ribavirin, 100 milligram per kg in divided dose. So the start dose, I'll give 2/3 of it as start dose, the remaining 1/3 over 8 hours, but not to exceed maximum of 7 grams. So subsequently from day 2 to day 7, patient will be on 5 milligram per kg, so as a single day dose. And between day 8 and 10, half of that will be given 2.5 milligram per kg as a single day dose. So I also recommend supportive care, which will include food therapy, nutrition, cardiovascular support. Then one important thing is also a psychosocial support. This patient will be in isolation, knowing the morbidity and mortality associated with Lassa fever, so can actually be a psychological stressor. So then I'll keep also assess the patient for possible complications. I'll manage accordingly, take care to a lot of patient might renal replacement therapy, the cardiovascular support, the respiratory support, and the like. Then we'll keep monitoring the vital signs and labs, including the viral load every 5 days to monitor response to treatment. So, and if PCR comes back negative, what foundation of treatment of bacteria is at discretion of the management. But if it comes out to the positive, patient has to complete 10 days of the hybrid bacteria. So we by that day 10, you have to the viral load, not you the PCR. So if at the 10, PCR comes out to be negative, and patient is no longer symptomatic, patient is discharged and follow up quickly for the first 3 weeks, and subsequently more for the next 3 months. So during this follow-up, you are assessing complications, especially hearing loss. And since it's a male, so you have to also counsel him that if he has a partner that the first 3 months, because during the convalescence, the Lassa virus can still be present. So if he has to have a sexual relationship partner, has to have a sex. Then also I want to do a contact tracing. So those with no risk, low risk, and high risk. For those with no risk or low risk, I'll monitor them for at least 21 days. Even if develop symptoms, might take the Lassa fever treatment. And for those high risk, they have to start the post-exposure prophylaxis for the Lassa fever and also continue to monitor them. And for those high risk, you have to send them so the investigation for Lassa fever reaction and not positive the treatment. The post-exposure prophylaxis is given at the oral bacteria 500 milligrams 6 hours for 7 days. So what are the other complications? So the other complications I'll be looking at for include the patient can have severe central nervous infections such as coma, seizures, like then severe bleeding can ensue. The patient can go into respiratory distress, sepsis.
Dr. Taiwo,
Yes.
your network, your voice is muffled. Network is bad.
So
Can
what
you
was
maybe shift
Where
a corner?
all right, okay. Sorry. Is it better? Hello, Chief.
It sounds better.
All right. I'm sorry. Okay, maybe do you want to take the when was the last thing you heard? Do you want to go back to
You go a very long way because I thought it was my network. My network is terrible. So
okay.
hopefully for somebody to raise it up again, that I was when I became sure that it wasn't from my end.
All right, okay. So let me just go over the so how will I manage the patient? So
Dr. Ekele,
Ma?
you
Okay,
know
I think
where
hello, ma.
we're hearing him, even if the network was kind of it was stuttering. So maybe you can start from here.
All right, okay. So how will I manage the patient? So first thing is having established that there is a suspected or probable case of Lassa fever. First thing is to put the patient in holding area and institute infection prevention measures. So also alert the relevant authorities and also bring other disciplines into the management. But top on this would be the infectious disease team. So I've sent my samples as earlier as said, both for the supportive investigation and diagnostic investigation. I'll transfer this patient to the treatment bay as soon as possible because they said that the patient start treatment before they sick is actually a pointer to good prognosis. So I'll start treatment with hybrid ribavirin using either the rural regimen or the McCormick regimen. So the loading dose for the rural regimen is 100 milligram per kg in divided dose, not exceed 7 grams. So 2/3 of the start dose will be given immediately, while the remaining will be given after 8 hours. So then subsequently from day 2 to day 7, you give 25 milligram per kg as a single daily dose, and between day 8 and day 10, you give half of that, that's 0.5 milligram per kg as a single daily dose. So you also want to commence supportive care, which include fluid therapy, nutrition therapy, cardiovascular support, respiratory support as needed. An important one to support is also the psychosocial support, because patient will be in isolation and knowing the complications that come with Lassa fever, that might be a psychological stressor for such individual. They also assess patient for possible complications and you manage accordingly. So monitor vital signs and you review the labs probably on day 5. So to monitor the patient's response. And if PCR comes out to be negative and you are still suspecting that patient could still be a case, so you might need to pick this after 72 hours. Whether to stop or continue will be at the discretion of the management team. So so you review the patient the individuals to complete the recovery for 10 days. So if the PCR comes out negative and patient is no longer symptomatic, then our work patient for discharge and follow-up will be weekly for the first 3 weeks and subsequently monthly for the next 3 months. So while on follow-up, what you're assessing is you're assessing complications, especially the hearing loss, which would come even after 3 months. Then you also want to counsel him since if he has a partner that the Lassa virus can survive up to 3 months. So it has to be protected sexual intercourse. So I also want to do a contact tracing for those that have come in contact with this hospital, which I will stratify into no risk, low risk, and high risk. For the no risk and low risk, you monitor for at least 21 days. Anyone that comes down with the symptoms, you institute the management. But while for the high risk, you start them on post-exposure prophylaxis as soon as possible, and you send for the test, and anyone that comes out positive, you initiate the institute treatment as soon as possible. And for the post-exposure prophylaxis, giving an oral ribavirin 500 milligrams 6 hourly for 7 days. So complications that come up include acute kidney injury, severe central nervous system features, severe bleeding, respiratory distress, sepsis, hearing loss. So what are the prognostic indices? Prognostic indices include the abnormal bleeding, encephalopathy, shock, then late commencement of ribavirin after 6 days of onset of illness, the poor prognostic factor, then the age less than 5 years or greater than 50 years, then if complications like acute kidney injury has set in, then elevated serum AST greater than 150 international unit per mil is also a prognostic factor. Then if it's a female pregnancy is a prognostic factor. So I'll just do a quick overview of Lassa fever.
Okay, Chief, please can you run through it in 1 minute because the time is up?
All right, okay, no problem. So we all know that it's one of the viral hemorrhagic fever and belongs to the RN viral, and outbreaks is usually around December and April. So important thing we have to know is we have to know what the alert case is, which then person with unexplained fever, with or without bleeding. Then the suspected case is anybody with fever for 3 to 21 days. For 3 to 21 days without vomiting, diarrhea, some of those symptoms are also presented with. And the probable case would be someone who has those a suspected case has fever within 3 to 21 days and with any of these which we can check off. Then the confirmed case would be someone that has returned back with a positive PCR for Lassa fever. So some of the questions we have, I think talk about this. Then pathogenesis, when the virus gains access into the cell, it tends to replicate and present itself to the antigen-presenting cell, which will trigger immune response, T cell, and cytokines, and this will lead to endothelial cell damage, platelet dysfunctions, suppressed cardiac functions, cytokines, and other soluble mediator of shock and inflammation. So, and the clinical features, incubation period is 25 to 21 days, can be asymptomatic. Any of the system can be picked, and I've talked about diagnosis, investigation. So, treatment has highlighted. So, I did mention I will use the ROAS regimen in my management. So here, this is the McCormick's regimen. The loading dose is 33 milligram per kg. So we give a start dose. Then on day 1 to 4, you give 16 milligram per kg 6 hourly, and day 5 to 10, you give 8 milligram per kg 8 hourly. Then we can check this out. Then some of the supportive care which I highlighted, and these are other differentials. So complications I talked about it. Then for discharge criteria, I mentioned it, but if the patient turns negative or is still symptomatic, so you might just want to step down the patient and monitor for a while. But if the patient returns back with a positive result after day 10 and symptomatic, so you might extend the treatment for another period of 5 to 10 days. Then this recommendation, I mentioned that. Then the prevention will be primordial prevention. Education is important for food storage, avoid spreading food on high table because it can easily be infected by the rodent. Then primary prevention for those with contact, so you start your post-exposure prophylaxis. Then secondary prevention, tertiary prevention as follows. Thank you very much. So these are my references. I also want to acknowledge Dr. Atta because I use some of his slides. Thank you very much.
Wow, thank you so much, Dr. Taiwo, for that beautiful presentation. Thank you so much. So now we'll take comments and questions from the participants first, and then before we go on to our teachers. Okay, sorry about the network glitch. Okay, so let's give it thanks coming on the chat. So there's a lot of thanks to you, Dr. Taiwo, from Dr. Kute, Dr. Florence, Dr. Yahya, and then Dr. Justice is saying, thank you, thanks a lot for a beautiful presentation. The network wasn't excellent, sorry about that. I think it would be important to mention that you will institute the contact tracing early in the management rather than bringing it up after patient's care. This is particularly important for this person who lives and works in close contact with other persons. Then an early audiometry may be important as well, since he already has some tingling sensation. The investigations, EUCR, clothing profile, etc., may be monitored serially to detect early deterioration and institute prompt interventions. Thanks a lot, Chief. Thank you, Dr. Justice, for that beautiful add-on. Okay, and then the others are thanks. Okay, I can't see any hands up. Can't see any hands up yet. Okay, our time is already far spent. Okay, so I'll hand over to our teachers. Mark Christabel.
Well, thank you, Dr. Claire. The presenter, the part I met, quite clear. Thank you so much, Dr. Taiwo. Chief Chitusa, Chief Emile, Chief Cookie, Dr. Datu is in class, he's the infectious disease specialist. Dr. Datu, any comment? Dr. Kopi, Dr. Fatima. Okay. Dr. I think you have a question in the chat.
All right. Okay, so Dr. Yusuf Rahim also just added, thank you for the lucid presentation. Presence of comorbidities is also a poor prognostic factor. Okay, maybe you can add that, Dr. Taiwo.
All right, thank you.
Okay. Thank you so much. Thank you. Like, I think you did so well. You've left our facilitator speechless. Thank you so much. Thank you. Dr. Okele, I think we should move to the next presenter. Thank you.
All right, thank you so much, Ma. Okay, so Dr. Taiwo, you cannot share. Okay, so Dr. Temi Adeyanju.
Yes, good morning, I'm here.
Please, you can share your slide. Okay, put it on slideshow. All right.
This is it on slideshow.
Not yet.
Okay, sorry.
Hello, Dr. Temi, any issues?
Colleagues. Good morning, our teachers and colleagues. I'll be taking practice question 5A. Next slide. The question says, a 47-year-old man with typical MI with blood pressure of 80/50 millimeters of mercury for about 2 hours despite inotropes. Serum EU creatinine was normal. He had a CT coronary angiography done. Subsequently noticed cold extremities, markedly reduced urine output, and some skin rashes. Also noticed to have low BP and tachycardia. 2 days after the procedure, his serum urea level went up to 10 millimole per liter, and serum creatinine rose to 300 micromole per liter. Urine microscopy showed granular cast. A, what is the diagnosis? B, what are the possible causes? C, how will you investigate? D, how will you manage? E, what medication will you give the patient when stable? Next slide. What is the diagnosis? The diagnosis here would be acute kidney injury secondary to cholesterol embolization syndrome. What are the possible causes? For this index case, the cause would be the coronary angiography which the patient had, which had possibly dislodged a clot to the renal vessels. Then the second cause in this case would be the background heart disease, most likely the myocardial infarction, which is an atherosclerotic condition, which is also a risk factor for the disease. Other risk factors present in the patient is the male gender. Other risk factors would include age, although it is said that notable risk factor is age above 50, but the patient is 47, so that does not really fit in. But others would include hypertension, diabetes, hypercholesterolemia, smoking, peripheral vascular disease, or CKD. How will you investigate the patient? For this patient, the definitive mode of diagnosis is the renal biopsy, which you expect to find biconvex needle-shaped cholesterol clefts, or what are called ghost cells. You can also find fibrinoid necrosis. And also for this patient, you want to do erythrocyte sedimentation rate or C-reactive proteins, which are inflammatory markers, and inflammation is one of the pathophysiologic mechanisms involved in this disease condition. Full blood count you expect to see eosinophilia. I also want to do a urine microscopy, which will demonstrate eosinophils in the urine. Urinalysis also may or may not show proteinuria. Then I want to do urine electrolytes, which would help me differentiate the AKI the patient is having, if it's pre-renal or intrarenal. Other investigations that would demonstrate other organ affectation would also be done. That would include creatinine kinase to see if the muscle is affected, a serum amylase to see if the pancreas is affected, then ANA and rheumatoid factor to rule out autoimmune diseases. Now, for this condition, complement assays is also important because it's been noted to be low in patients with cholesterol embolization syndrome. How will you manage? Management of this condition is multidisciplinary, which would involve the cardiologist and the nephrologist. The first role of management would be resuscitation, which will be done by optimizing the airway, the breathing, placing the patient on oxygen if saturation is poor, and then the circulation. We want to put a central line for the patient as patient is presenting in hypotension and features of poor renal perfusion. Then I want to commence the patient on ionotropes, which would help elevate the blood pressure and even assist in renal perfusion. Like I said, inflammation is one of the pathophysiologic mechanisms, so steroids have been shown to improve, minimize symptoms in this patient. So I want to give corticosteroids or colchicine. For this patient who had an elevated creatinine 300 microgram and urea of 10 after 2 days, patient meets indication for dialysis. So I want to carry out a continuous renal replacement therapy for this patient. After this acute management, I want to manage the risk factors for the condition, which will be addressing atherosclerosis. What medication will you give the patient when stable? For this patient, once patient is stable, you address the risk factors like you give statins. Statins have been known to stabilize plaque, so you want to reduce the risk of further embolization. And also they have anti-inflammatory function, so statins will come in. The antiplatelets and all would also come in. Now, briefly, cholesterol embolization syndrome has to do with embolization of the cholesterol crystals usually from a proximal large artery like the aorta to distal arteries, the renal, the guts, the skin. And it usually follows an intra-arterial procedure, majority of cases, either angiography, angioplasty, stent, or arteriography. In a few percentage of cases, it can actually be spontaneous. Next slide. And there are 3 forms of cholesterol embolization syndromes. It can present as acute when it develops a few days after an exciting event. And this one is usually due to a massive embolization, and it gives a markedly elevated creatinine, an immediate marked rise in creatinine. And then it can be subacute, where you have a stepwise manner of rise of the serum creatinine from days to weeks, or it can be chronic. The risk factors, like I mentioned, these risk factors are usually risk factors for any atherosclerotic disease, your non-modifiable and your modifiable risk factors. The pathophysiology involves displacement of the plaque to distal vessels, and this plaque, they lodge in these vessels and cause obstruction to the vessels, thereby affecting perfusion or blood circulation to that vessel. Following this, there is a stimulation of an inflammatory response, which would lead to production of cytokines that would also complicate or that will also further cause inflammation destruction of the end organs that is being supplied. The clinical features, there are different organs affected in cholesterol embolization, but most commonly is the kidney. So it could present, like I mentioned, either acute or a progressive form. For the acute form, you have features of AKI, the reduced urine output, hematuria, plus or minus proteinuria. For the skin forms, you have these due to the obstruction of those end vessels, there's this retiform purpura, blue or purple tools, presence of ulcers, gangrene, or even livedo reticularis. They could also have a small naked infarcts. For the GIT, they present with abdominal pain, flank pain, GI bleedings, whether upper or lower, and then they have some other constitutional symptoms like fever, myalgia, anorexia, and fatigue. This is a picture showing livedo reticularis, the upper picture showing livedo reticularis. You have this net-like and purplish rash on usually affecting the lower limbs of the patient. Then the lower picture shows the blue toe syndrome due to obstruction of the vessels perfusing the toes. Now, the differentials of this condition, contrast nephropathy is a close differential because you also have deterioration in renal function following use of contrast. Contrast is also used in coronary angiography, so it can be a very close differential. However, you would not expect to find these characteristic skin conditions like the purpura or the livedo reticularis or the blue toe syndrome in the setting of contrast nephropathy. Other differentials are as shown. Next slide, please. Okay, this is just a table showing the differentiating factors between the two conditions. Like I said, they are very close differentials. So what you use, one, the skin manifestation, then two, the complement levels. You expect it to be reduced in cholesterol embolization syndrome, where you have a reduced complement 3 and 4. And then the inflammatory markers would also be high in this setting. So you see a elevated ESR and CRP. One other differentiating factor is the blood pressure. You can also use that to differentiate because in cholesterol embolization syndrome, due to the reduced renal perfusion, the RAS system is activated. So you might end up having elevated blood pressure, which you might not likely see in contrast-induced nephropathy. Next slide. So diagnosis, I've mentioned this. Next slide, please. And then treatment, similar, resuscitation, supportive. Additionally, you can use vasodilators. They've been shown to help perfusion. However, in this patient, the blood pressure is low, so you would not be able to use it at this time. Then there are some other medications that are being tried for the condition. Surgery is also important if there's no improvement. And then for prevention of cholesterol embolization, you want to minimize aortic wall rupture during those intraarterial procedures. You also want to use soft, flexible catheters in carrying out the procedure. Avoid brachial or avoid high pressure jets of contrast material, which can also dislodge those plaques. Then the brachial or axillary approach would be preferred. Prognosis is poor. However, regain of renal function have been shown following dialysis. 30% may progress to end-stage renal disease, and death can occur in 28% of patients. Thank you very much.
Wow, thank you so much, Dr. Onelum, for that lucid and concise presentation. Really kept the time. Thank you so much. It was beautiful. Okay, so now we'll take comments and questions from the participants first, and then keep the thanks coming on the chat. Okay, I don't think I can see any comments yet. Okay, you can raise your electronic hands if you want to make a comment. All right, so there's a comment on the chat. There's some comments. Thank you so much from Dr. Jamila Bashir, thank you very much. I thought it was contrast nephropathy after reading the question. You really helped with this presentation. Okay, so Dr. Adeyemo Adedapo says, thank you for the beautiful presentation. Please, what are the factors in this patient that exclude the diagnosis of contrast nephropathy? The rashes could have also been reaction to the contrast medium used, and also considering the fact that serum creatinine prior to the procedure was normal and started rising 48 hours post-procedure. Skin rashes were poorly described. BP can also be low in contrast nephropathy. All right. Dr. Nelum, please, you want to react to that? So they're trying, you want to react to that?
Yes, like I said, they are differentials of each other, and differentiation might be a bit difficult at times. But for cholesterol embolization, the skin rash is a very significant marker of the disease. Although it was not properly, the type of rash was not properly defined in this case. However, if you have seen some of the other recalls of this particular question, for some people there's addition of a Bluetooth syndrome or a better explanation of the rash, and they explained maybe the net-like appearance of the rash. So that was what I used to choose cholesterol embolization.
All right, thank you. Dr. Conte, please go ahead.
Yes, good morning, colleagues and teachers. Can you please go back to the question? Because this issue about differentiating between the contrast and cholesterol embolism is very important. I think the giveaway is in the procedure that was done. So they mentioned that specifically it was a CT coronary angiogram. So mainly with the cholesterol embolism, it is procedure wherein you introduce catheters into the great vessels, and those catheters are the ones that can now dislodge those plaques and then cause the embolization. The CT coronary angiogram, unlike the traditional coronary angio, which is done in the cath lab, the CT coronary angiogram is non-invasive.
Pressure.
Okay, so the CT coronary is non-invasive. You inject the contrast from a peripheral vein, and then you do CT scan sequences to look at the coronary angiogram. Whereas if this was a coronary angiogram procedure that was done in the cath lab, then it put them at risk, especially for procedures that you're going to make use of the abdominal aorta to access. In fact, because of this cholesterol embolization is one of the main reasons why the preferred access now for coronary angiogram is the radial access, okay? Because in the radial access, you don't traverse the abdominal aorta. Whereas if you use femoral access, which sometimes we have to resort to if you do not have good radial access, then that puts them at risk for cholesterol embolism. But since this one specifically they mentioned CT coronary angiogram, it is non-invasive. So the most likely we are dealing with here from the question that was given would be a contrast-induced nephropathy. Thank you.
Well, thank you, Dr. Conte, so much for that clarification. Okay, Dr. Amakri will talk next, but let me just ask my question so that she can also make an input to it. I was wondering why you wanted to do a dialysis in this patient.
Okay, the question mentioned that there was a rise in creatinine of rise in urea of 10 millimole and creatinine of 300, and the patient is hypotensive with markedly reduced urine output. And dialysis has been shown to improve these markers. That was why I thought it would be important to do that in this patient.
All right. Okay, Dr. Amakri, please go ahead.
Good morning, my teachers and colleagues. Thank you so much for your presentation. Okay, as a way of making diagnosis, you suspect this cholesterol embolism when you have a subacute kidney failure, like our patient they mentioned previously that his creatinine was normal, then there's a sudden deterioration of the creatinine. Then after subacute kidney failure, after a vascular intervention and reticularis. Then it's also said that it usually originates from an upstream unstable atherosclerotic plaque, where they did an intervention for him in the cardiovascular region upper there, and it will now cause a downstream partial occlusion, and the downstream for him was his kidney. Then for secondary prevention, you mentioned the treatment. For secondary prevention, we also have the use of statins, aspirin in these patients. Although this patient came hypotensive, I think if he's after resuscitation and all, maybe when he's getting better, his BP will come back to normal. And most of them present with hypertension because of the stimulation of the RAS system. So we're going to control the BP, advise patient to stop smoking, and also if patient is diabetic, control DM. Then for the question Dr. Ekele asked, well, we don't know the we didn't see the full question. They mentioned deterioration of the urine output. They didn't give us a figure if it was anuric that we will need dialysis. Then also the urea and creatinine levels are not in the patient did not have it. They didn't mention any uremic symptoms in this patient, and we don't have any baseline for our to say this patient is already in acute, comparing our values now and the previous values to say this patient is already in an acute kidney injury stage that will go ahead to need dialysis. I think after management, patients should get better. But if we have clinical features suggestive of that patient should have dialysis, then we should go ahead. Or we have our baseline and we're having what to compare with. Then we can say, okay, patient has reached the stage where he or she will benefit from dialysis. Thank you.
Thank you
Thank
so
you
much.
very much. Thank you.
Thank you so much, Dr. Margaret. Please, I didn't quite get you right. So what do you think is diagnosed? Is it contrast-induced nephropathy or cholesterol embolization?
Cholesterol embolism, because he had a vascular, he had deterioration of his renal, his creatinine and urea. Then he had, following this deterioration, followed a vascular intervention, and also he had a rash, which is possibly a livedo reticularis.
All right, thank you so much. Okay, so there are a few more comments on the chat. Dr. Wakim is saying thank you. Dr. Laura Imariegbe is saying the timeline doesn't fit with contrast nephropathy, which will manifest about 48 hours. She's also adding CIN is acute, not typically associated with rash, cold extremities, or hypertension. Okay, okay, thank you so much, Dr. Laura. Sorry, Dr. Mark, I also want to confirm, what do you mean by subacute? You mentioned something subacute.
Okay, the deterioration was not, well, is the changes in the indices were not so high. I think from normal, it went to 310. Well, whether it's subacute or acute, it's depending on the amount of the emboli that went to the emboli that is affecting the kidney. So the deterioration of the kidney function is not so marked. That's why I stated that it's subacute.
All right, thank you. Dr. Sorry, is this a new hand or an old one? All right, thank you so much.
It is the old hand. Then possibly just to mention that probably it's a recall problem, but the CT coronary angio is non-invasive. That is very important. And it's usually the invasive procedure that dislodges the cholesterol plaque and causes the cholesterol embolization. Thank you.
And thank you so much, Dr. Sori. Thank you, Dr. Macri, Dr. Laura Arnold, who contributed. Thank you so much, Chief Dr. Kopi, for sharing. Okay, Ma, I'll hand over to you now. Let's hand over to our teachers.
You so much. Thank you so much. Chief Laura, Dr. Ekele, Chief Laura is one of our wonderful chiefs, one of our facilitators. Thank you so much, Ma, for joining us. I know the timeline and all, I know it's a big sacrifice to still join from where you are. But I appreciate you, Ma, and we appreciate your comment. Thank you, Chief. The presenter, thank you. Dr. Sori, thank you. It wasn't a recall problem. I remember something commonly, if something is commonly seen with a particular procedure, doesn't mean others can cause it. Even though it's more with invasive procedure, CT coronary angiogram, CT abdominal angiogram, any of the angiogram, as far as contrast is used, there's a possibility that it can also cause, just like the way our dear Chief Laura also mentioned, and Dr. Amatri, I think so. Yes, I got it being a ball. Remember, even though rash is commonly seen in contrast induced, but most times it's not one of those symptoms they want to project to you. Now there's a contrast, patient had an angiogram, patient have a renal issue, a patient have a rash. Most likely they are trying to, because of the presentation can be quite similar, contrast-induced nephropathy and this cholesterol embolism. They're very similar, but most times once they're projecting a rash at you, just know that, oh, wait, I'm still on record. I'll say this in later. So thank you so much, everyone. Thank you. I appreciate you. Chief Remigus, I don't know. Chief Remigus, Chief Chitu. I don't know if you guys have any comments.
Yes, Dr. Christopher, yes. I didn't understand. There was a statement that was made that I didn't quite get. Subacute kidney failure or something? Or was that what I heard? I was driving at the time, so I don't know if I misheard that. Hello?
Sir, you heard right. It was Dr. Macri that mentioned it.
Okay.
You heard right.
Please, there are nomenclatures we use to describe problems with the kidney. There's this KDIGO write-up. It's readily available about nomenclature and stuff. So there's some things we don't say. If a person meets criteria for acute kidney injury, here we didn't give us the parameters to be able to point towards any of the particular indicators of acute kidney injury. So we can't say categorically that the person had acute kidney injury, although it could suggest it. Because there is nothing like a normal creatinine per se, okay? For everybody, that is. Everybody's creatinine is personal. I'm about 6'2" tall, and my normal creatinine would definitely be higher than someone that is 5 feet tall. Okay, because I will have a larger muscle bulk and I'm a lot bigger. So usually that's why many nephrologists, we don't look at the normal range they put in front of us, because a person's normal range for one person could be abnormal for another. So let's keep that in mind. Also, if the person doesn't meet criteria for AKI, meaning one of those 4 indicators of AKI that we all know, okay, what you would prefer to say is that there is an abnormal kidney function. Okay, that's the appropriate term. Okay, some people say deranged renal function, but I think that has been cancelled out completely. If you check that write-up on nomenclature by KDIGO. So it just say the person has an abnormal kidney function, okay? Till you can now say, yes, person has a particular entity because he has met the indicators for that entity. Okay, in this case, AKI, if he has met it. Now, also, nomenclatures that have been phased out is end-stage kidney disease. Yes, it has been phased out. It's actually, you just say kidney failure. Okay, if you read that document, it's written like that. They just say straightforward kidney failure. So please, let's avoid, because if you say that kind of term, they're going to ask you to define it. And honestly, there isn't a definition for that, okay, based on the current nomenclature that is out there. Okay, so I would rather we say something like an impaired kidney function or abnormal. That's how they actually wrote it in that guideline, abnormal kidney function. That's just what I wanted to add.
Okay, thank you, sir.
Very well.
Thank you. Dr. Kopi.
Hello? Thank you. Hello? Can you hear me?
I can hear you, sir. I can hear you, sir.
Yes, sir. I can hear you. Yeah, I wanted to contribute to the little controversy. I don't know, maybe at the end, someone that was there could still contribute to tell us what they actually. the diagnosis by the presenter was okay, was right, but it could have actually also been the CIN. Although, yeah, usually it's 48 hours. I thought that was what the question said. Usually after or within 48 hours of exposure to contrast. Okay, so yes, it's possible. And I think is defined as, is it 25% increase in serum creatinine or 50%? I've forgotten that definition. Okay, so following 48 hours following exposure to contrast. Okay, so it's possible, it's a differential, and that's why the presenter actually talked about both of them. Okay, so if you are asked and you say one and you notice that the person in front of you is not, too happy with what you said, you can also mention the other one. So those are some of the tricks of the exams. Okay, so but that be that as it may, the presenter actually did very well. Okay, it was a very good presentation. Thank you.
Thank you, sir. Thank you so much. Dr. Kopi, has he spoken? Okay, cool. It's past 7 already. Dr. Kopi, go ahead.
Okay, thank you so much, ma. I don't want to say the negative or the opposite side of what we're saying. We are on the right track, but I also just want to stand with what the third line of Dr. Conti. If a cardiologist may not go for the cholesterol emboli from the first view, knowing fully well that the investigation is not invasive. But for Dr. Conti, if you look at the history very carefully, it looks like they are painting something of an RCA-MI, which will require an invasive procedure, despite ionotropes and stuff like that. And also the other presenting complaints of lower extremities, and then particularly the rash. So the symptoms, the presentations were actually more in keeping with cholesterol emboli. So just taking the CT contrast coronary angiography alone as a standalone point, it might just be that maybe the recall was not properly done. But for a general medicine platform, yes, it's better we go for cholesterol emboli. But if it is for